Fetal growth restriction is a leading cause of perinatal morbidity and mortality. Historically, multiple terms have been used to describe a fetus that has not yet reached its growth potential, including fetal growth restriction and small for gestational age, or SGA. Fetal growth restriction is commonly defined as the ultrasound estimated fetal weight less than the 10th percentile, while SGA is defined as the birth weight less than the 10th percentile for that gestational age and sex. The prevalence of SGA has been estimated to be 10% in the United States. Fetal growth restriction is associated with stillbirth as well as neonatal morbidity and mortality due to issues with hypoglycemia, hyperbilirubinemia, hypothermia, intraventricular hemorrhage, necrotizing enterocolitis, seizure, sepsis, respiratory distress syndrome, and even neonatal death. When growth restriction is suspected, early induction of labor is often recommended to prevent stillbirth. The ideal approach to induction of labor and the setting of fetal growth restriction remains an ongoing debate. Some evidence suggests that administration of prostaglandins may improve vaginal delivery rates over oxytocin alone. However, the association of prostaglandin-induced tachysystole and then fetal heart rate decelerations has prompted many clinicians to advocate for avoidance of prostaglandins in the setting of fetal growth restriction. The objective of this study was to determine whether prostaglandin use for cervical ripening for induction of labor was associated with increased odds for cesarean delivery in nulliparous women with SGA neonates. We performed a secondary analysis of the Nulliparous pregnancy outcome study monitoring mothers-to-be or new mom-to-be. This prospective observational cohort was established to identify risk factors predictive of adverse pregnancy outcomes. We included women with cephalic presenting fetus who underwent induction of labor with a starting cervical exam 2 centimeters or less. Participants were excluded for prenatally diagnosed fetal anomalies or with a prior uterine scar, as this is a contraindication to prostaglandin use. The primary outcome was mode of delivery. Vaginal deliveries included all operative deliveries, including vacuum and forceps. The secondary outcomes included fetal acidosis, non-reassuring fetal status as an indication for cesarean delivery, NICU admission, respiratory distress syndrome, intrapartum or neonatal death, 5-minute APGAR less than 7, maternal hemorrhage, and chorioamnionitis. Unfortunately, not all women in this cohort had a recent ultrasound that could have made the diagnosis of fetal growth restriction. For this reason, we instead used small for gestational age as defined as a birth weight less than the 10th percentile for that gestational age and sex. Multivariable logistic regression was used to adjust for potential confounders and test for interaction. Now on to our results. Among 2,353 women eligible for our analysis, prostaglandin use was used in 55% of inductions, SGA occurred in 15% of neonates, and 35% of women had a cesarean delivery. The prostaglandin and cesarean delivery association differed significantly for SGA versus non-SGA neonates. Cesarean delivery occurred more often in SGA neonates exposed to prostaglandins than those not exposed, 35% versus 22% with a p-value of 0.009, whereas prostaglandin use was not associated with cesarean delivery amongst normally grown or non-SGA neonates. This interactive effect remains significant when adjusting for confounders such as BMI, race, ethnicity, and cervical dilation on admission, as you can see in Figure 1. Additionally, as seen in Figure 2, among SGA neonates, prostaglandin use was not associated with adverse neonatal outcomes or postpartum hemorrhage. However, women who received prostaglandins did have a higher rate of chorioamnionitis. In conclusion, prostaglandin use was associated with a higher cesarean delivery rate in SGA neonates within this cohort of women. Thank you.